Sorry not to get it sooner.
Mm-hmm.
What questions you guys have? She wrote all the stuff on the board.
Yeah.
A little bit overwhelming probably, right? It's just the name of a lot of different medications.
Right.
So we know that you have a lymphoid malignancy. It's a acute lymphoblastic lymphoma. Leukemia. It's sort of, sometimes the terms are lymphoblastic lymphoma and acute lymphoblastic leukemia can be used interchangeably because you have involvement in the bone marrow. We don't really stage a leukemia. An acute leukemia is a process that's in the bone marrow, and so by definition it's leukemia. And it's not like if you had certain other diseases that we stage, like lymphomas and stuff like that. Okay? We treat it with what's called induction therapy, and the goal is to induce remission. That's why it's induction. And you're in here for the better part of a month. Maybe 3 weeks. Sometimes the counts come up around 3 weeks. When the counts start to come up and your neutrophil count, what we call absolute neutrophil count, or ANC, is over 500, then we can let you go. And then we bring you back to clinic, and when your counts are fully recovered, we do a marrow biopsy to document remission. And then there's sort of the next phase of treatment that we call intensification, and that's sort of to keep you in remission. And there are several of those post-induction treatment phases, and basically for several cycles, and then ultimately we do something called maintenance. Now we don't know a couple features of your leukemia, we won't for a few days, but the chromosomes, the cytogenetics that are associated with your leukemia are going to tell us if you are high risk or not, okay? There's something else called the Philadelphia chromosome, and if you had Philadelphia positive ALL, that would also put you at high risk. Based on your white count, you're not at high risk. It's a nice low white count, and so anyway, as we get more information back, we'll share that with you as soon as we know it, and we'll be able to give you a better idea of what's in store in the next several months. For those patients that come back high risk by virtue of their chromosomes, their cytogenetics, including the Philadelphia chromosome, we generally recommend a stem cell transplant. So that's kind of a pivotal fork in the road, knowing that information and knowing sort of where you stand. Obviously, people feel much better when they know what to expect. So we'll try to get that information back as quickly as we can. But the induction therapy is the same either way. Okay? And then you have all these, there are several agents that are active against your disease. Basically, let's see, where's the magic? Let's see. Hyper-CVAD, so there's actually another one here also. The VAD, V has been vincristine. And the A is adriamycin. So vincristine, adriamycin, dexamethasone, and cyclophosphamide are really the backbone of treatment for ALL. The Mesna helps you minimize bladder irritation because the cyclophosphamide can irritate the bladder. And the rituximab is an antibody that we use when patients have B-cell ALL. You happen to have B-cell ALL. It's an antibody against the B cells. So all of these work together very well to help try to remove these cells from circulation and do away with them. And it just comes in certain stages, basically, so that, did she leave that in here? Let's see. Do you have a sense of when you're getting things when? I mean, it's basically over the next few weeks you're going to get, for instance, rituximab first today. The cyclophosphamide, let me go get the sheet so I don't...
She has a tentative sheet, that handwritten thing
Oh,
up in
great.
green.
Oh, yeah. Oh, excellent. Who did this?
I'm not sure.
Okay.
Abby did that.
Mhm.
She wrote that all down.
We said we're visual people.
Oh, very good. Is Abby your nurse?
Abby and
One of
Ashley.
them,
Yeah.
Yeah, okay, this is great. So you can get rituximab on day 1 or day 2. It looks like they'll give it to you tomorrow. That's fine. So you're going to get your cyclophosphamide, and that goes in, and the other term is Cytoxan. That goes in as an infusion, and we give you Mesna at the same time and then a little bit afterwards. And that just minimizes bladder irritation. We're going to ask you to let us know if you have any burning when you urinate or if there's any redness. Sometimes people can have hematuria, which is bleeding in the urinary tract. Most of the time that doesn't happen. And we've given this drug for years, and you know to use the Mesna. It works quite well. You're going to get more of this on Sunday, more of the Cytoxan and Mesna, and then the rituximab. And then you get day 3 of Cytoxan on Monday with Mesna. Now, people who have lymphoid leukemia, or ALL, acute lymphoblastic leukemia, can be at risk for cells in the cerebrospinal fluid. So everybody across the board, even if you're low risk, we do a spinal tap to make sure you don't have any cells in there. And when we do the spinal tap, before we remove some fluid and send it off for a test. And before we come out with the catheter, we give you a squirt of chemotherapy because we don't want any of the cells from the blood to get into the cerebrospinal fluid. So that if you were negative to begin with, we don't want to make you positive. So anyway, we treat you with that chemo. It's prophylactic treatment. If ultimately those cells come back positive, the fluid comes back positive, then we know we're treating you because it was positive. But if it's negative, we're keeping it negative by giving you that treatment. You end up getting a couple treatments each cycle. And this cycle, it's going to either be Monday and Friday or Tuesday and Friday. Okay? And we actually send you down to fluoroscopy, which is down in radiology. They're going to be able to look with a fluoroscope essentially to determine exactly where you're the right place to go in your spinal column, and then do the spinal tap there, and then basically one of our doctors goes down and gives the chemotherapy right through the catheter.
When will he know whenever he's going to have the chemo, whether it'll be Monday or Tuesday?
Well, Monday morning they're going to call right away to fluoroscopy and say, we need an appointment for this afternoon.
I was just curious because I'm leaving Monday evening, and I was curious.
Well, they'll know. So if Monday morning they get an appointment for Monday, then it'll be Monday afternoon and then Friday afternoon. So they're going to either way say, they're going to say, look, we need an appointment for Monday or Tuesday and an appointment for Friday for intrathecal chemo. So they'll know Monday morning.
Okay.
So by the time you leave, Stephanie, he either will have gotten it on Monday already, or it'll be scheduled for Tuesday. And then, so it'll be Monday, Friday, or Tuesday, Friday. If they can't do it Friday, they could do it Thursday. So anyway, but between those days, that's when it'll be. Let's see, and then Tuesdays have been Christine, doxorubicin, and no chemo on Wednesday. You got to give you a break. And then Thursday is what we call growth factor, or filgrastim. That helps the bone marrow start to respond after we're hitting it with the chemo. And then on Friday, you have another dose of intrathecal chemo. Intrathecal means right here. Okay? That procedure is actually tolerated quite well. Easy for me to say. I have to acknowledge I'm not the one going through it. But patients generally do very well. When you come back from that procedure, we want you to lie down for an hour so that you don't have as much risk for a spinal headache. And then people generally do fine, but we just want to make sure that you're resting for an hour, and that helps minimize risk for headache. Sometimes we give you fluid during that hour and everything, okay? I know this is going to have your head spinning. We can go over multiple times, and that's appropriate. Don't feel bad about asking multiple questions over and over, that sort of thing.
I have a question.
Yeah,
The stem cell transplant, if needed for the high risk and all of that,
yeah.
how does that work? Is there a donor needed?
Yeah, although I'm hesitant to talk much about it until we know you might need it, because it's a long, it's kind of a long discussion, and that'll be even more confusing. And then if you don't need it, so that's. But it's basically we do have to. We check HLA typing on you, if we needed to, and then we check for donors.
I was curious because, like I said, his sister will be here tomorrow, and his brother would be here on Monday, and I know
Yeah.
it's sometimes from a sibling, and
Yeah.
his brother lives in Boston, and
Sure.
I don't know when he
We can send out kits and stuff like that, so it happens it's pretty efficient. Sometimes people are on the other side of the world, basically, and that sort of thing. So we're not going to know by then
Oh, I
because
know.
it takes the chromosomes a while to come back and everything. These are full brother, full sister?
Yeah.
Okay. If we needed to address it, then we would certainly, get their, if they wanted to leave their address and phone number, if we come to that, our bone marrow coordinator will call them and basically send out kits, and it's just they could do a little sample with a popsicle stick swab of their cheek for DNA.
Right.
That's how streamlined it's become. And if we don't need to, then so much the better.
Right.
How are you hanging in, alright?
Yeah.
Feeling pretty well? Feeling
Yeah, I feel
okay, yeah. Probably hard to believe all this is happening because you feel fairly well.
Right.
Yeah.
Yeah.
Well, I think, take it. Our advice is to take it one day at a time. To try to kind of grasp what's happening today, and then after a few days, generally, people say, okay, I think I get the drill. I can do this. But of course, it's totally new stuff,
Yeah. Yeah, so far it's bearable, but I realize things are going to change.
Well, you may feel a bit punkier as you go through the treatment, and yet you're going to have some days when you feel pretty good. And we do encourage you to continue to walk around the pod and be up and mobile and stuff like that. Then again, if you're feeling lightheaded, or like you might faint or something, let the nurses know. Then we'll give you fluid or blood. We do encourage you to pee sitting down, which is not what men are used to, but there's a risk for falling, fainting sort of when you're peeing, and especially in the hospital and stuff. Better to be sitting on the toilet. All right. We don't tell people that as much as we should. So invariably, things happen sometimes where, somebody's standing up and next thing you know, they're on the ground. If your platelets are low, which yours are going to be progressively lower because we're giving you chemo, we don't want there to be any risk of bleeding and stuff. Okay?
He's not one of those men with a big ego, so I think he'll be okay.
Yeah. Well, I think it's just by habit,
Yeah, I don't know where to put my bag when I sit when I do sit to take a dump in there. I never, my bag's not comfortable in either place. It's in the front one, it gets wet from urine.
Yeah.
But yeah, whatever. Yeah. So, yeah.
Do you understand what he was trying to say?
As in, my scrotum.
Yeah.
Can't find a comfortable
Yeah.
Yeah.
I thought that's what you meant, but yeah. So let's see how today goes. I'll be around tomorrow. The person rounding initially during the day is Dr. Bernhardt, the fellow, but I'm around. I'll definitely poke my head in and see how you're going, how things are going and stuff. Okay.
Yeah, she's the one that did the thing yesterday.
Yeah.
Yeah, that was amazingly painless.
Yeah, you hear horror stories of bone marrow.
You do.
biopsies.
My mother just chatted with me through the whole thing when she had one, and yeah, it's extremely variable, and some patients say it's not a big deal. You can get an 80-year-old woman saying it's no big deal. You get a 20-year-old Marine saying it's the worst thing I've ever had. So it's just no rhyme or reason kind of, but Dr. Bernhardt's good. She's, sensitive and takes her time and all that stuff, and that's part of it. And then obviously, like anything else, you can have a painful one or one that goes pretty well, but the more you have that go well, obviously the less anxiety provoking it is.
Right.
All right?
Okay. Yeah.